Hello, good morning everybody. So I'm going to be talking to you today about combating cross-infection risks in ultrasound with effective and efficient solutions. So by the end of the talk today, we'd like to give you an insight into why ultrasound is a high-risk area for cross-infection, what research tells us as best practice methods to high-level disinfect ultrasound probes, what is the effectiveness of using UVC high-level disinfection, and how using UVC can be a sustainable, ultra-fast method of improving compliance while saving costs. So firstly, as you all know, and you're all part of, it's our jobs to try to reduce hospital-acquired infections. And up to 70% of hospital-acquired infections are preventable using existing practices available, such as products I'm going to be talking to you today. So ultrasound is a very unique area because we have one medical device that can actually be classified in every single element of the Spalding classification. So we have an ultrasound probe that can be used on intact skin and therefore classed as non-critical. But at the same time, it can be used for non-intact skin and sterile tissues. Therefore, it makes it quite a confusing reprocessing element for the end users. And therefore, it's our jobs to give them good education into where and how they should be reprocessing their ultrasound devices. And obviously, as you know, if they're not conducting high-level disinfection, then there's a lot of microbacteria that they could be missing if they're only conducting low-level disinfection or ineffective disinfection, such as HPV or norovirus. So to high-level disinfect the ultrasound probes, there's different methods. They could be automated or manual operator-dependent methods. And at this point, I'd like to introduce Ursula Morby, who's a decontamination lead, who's going to be talking to you today about her research into what is the impact of automated high-level disinfection on microbial colonization in ultrasound probes.
Good morning, everybody. Thank you very much for having me today. So I'm going to go through my thesis with you on what's the impact of automated high-level disinfection on microbial colonization in ultrasound and endocavity probes. So as Pavan said, I work on the west coast of Ireland. I'm decontamination lead and SSD manager. My remit covers 1 Model 4 hospital and 4 Model 2 hospitals with a wide range of departments across all sites using ultrasound and endocavity probes. I completed my thesis using a systematic review. I wanted to research this area because I noticed that there was a shortfall in education in my group surrounding ultrasound and endocavity probes, and most were not using an automated system at all. Ultrasound is perceived as a safe and effective way of diagnosing and treating a wide range of medical conditions, but some users in our group, my group, and I presume everybody's group, are not aware of the importance of the correct decontamination processes and the harm that we can cause with ultrasound and endocavity probes if they're not disinfected correctly. So I completed my research in a systematic review, and our goal as clinicians is to provide our patients with the most up-to-date services while also protecting them from developing healthcare-associated infections. We need to increase the users' awareness of the link between microbial colonization and the use of endocavity and ultrasound probes. I use a systematic review method to do this, and I searched through CINEL, PubMed, Embase, Medline, and Google Scholar for my grey literature. And grey literature has arisen as a critical complement to commercially published research in systematic reviews. From there, I used the PICO method, which helped me clearly identify and frame my research question. And the search processes was conducted using specific keywords, databases, inclusion-exclusion criteria, and then my PRISMA. So I used a PRISMA framework 2020 then for each of my databases that I searched, and that led me to one overall PRISMA. So in total, I reviewed 289 articles, and using all those tools, it led me to find 11 articles that were suitable for inclusion into my research. My research actually leads it to a narrative synthesis rather than a meta-analysis. So using the PICO population for me in this was ultrasound and endocavity probes. The intervention was the use of automated high-level disinfection as opposed to manual wipes. And the outcome, my main outcome, was microbial colonization on ultrasound and endocavity probes. And possible second outcomes that I used would be incidences of healthcare-associated infections and education and training. Of the 11 articles that I researched, 10 articles had microbial colonization as their main focus. So from this slide here, we can see that Casilengo found that human DNA was detected on 36 post-examination samples and 28 pre-examination samples, and probe contamination with a high risk of HPV and DNA after low-level disinfection, despite the use of probe covers. Frazee noticed the prevalence of microbial colonization on ultrasound probes between patients. Ali discovered that 43% of probes had low-level disinfection or no disinfection at all, and 43% before use and 67% after use. Bouchier found that the automated disinfection system had a much higher success rate of 91.4 compared to 78.8 for the manual disinfection, and the risk of contamination was increased by 2.9-fold when people used manual disinfection. Sartoretti's article showed that the cultures from probes showed a mean of 53 CFUs before and 0 CFUs after training. Nigu was one that conducted a prospective study. They separated the probes into two groups, those that had gluteral disinfection of the head only and those that had automated disinfection of the head and handle. All the probes had been cleaned with detergent and water and dried after use, and 77 were processed using the glutaraldehyde method, and the 75 were used automation of the head and handle. The bacterial contamination obviously was higher on the probes from the glutaraldehyde group. Coombs noted that disinfectants that are used tend to have limited virucidal efficacy against HPV type 16 and 18, and both of these problems combined could result in the transmission of HPV. So these comments are from studies concerned with transmission of healthcare-associated infections to our patients and question the current low-level disinfection methods as opposed to using an automated high-level disinfection. And we can see here there inefficient probe covers possibly causing an infection risk of contamination due to probe handles not being effectively disinfected, higher CFUs counted noted on ultrasound probes in comparison to public places, which I'll touch on later. Microbial colonization is not removed by wiping alone, and reclassification of ultrasound probes as semi-critical. The running theme is that we can actually, hang on there we are. So what does our research tell us? It's 80% of the probe handles were not disinfected, and they had residual pathogens, including MRSA. It tells us that 18% of ultrasound probes were found to be contaminated with human DNA after incorrect disinfection. HPV and DNA are routinely detected on TB probes after incorrect or inadequate disinfection method used despite using a probe cover. And 13% of probe covers have tears pre and post ultrasound examinations. 43% of probes may have encountered sterile tissue, had only low-level disinfection or no disinfection at all. And bacterial contamination of ultrasound probes prior to disinfection training showed a higher bacterial load than toilets and bus poles, which I will come to. We can see from this slide the damage and risk involved through lack of education. Improved education for all staff is essential. When users are educated, the risk to our patients acquiring a healthcare-associated infection is reduced. Would any one of us like to have a probe like this used on us, but do we actually take any notice of the probe when we're having an ultrasound scan? I know I probably wouldn't have previously, but I do now. So what were the findings? The running theme is that ultrasound probes, if not cleaned and disinfected using automated high-level disinfection, can cause microbial colonization, thus increasing the risk of healthcare-associated infections, with HPV being the most prevalent, along with MRSA. There is need for an ultrasound and endocavity probes to be seen as potential vectors for contamination for our patients. Automated high-level disinfection is more effective at contaminating ultrasound probes, which improves our patient safety. Now, Sartoretti's article was the only study that collected swabs before and after training and compared them with samples from public spaces, which revealed that public spaces such as bus poles and toilet seats contain fewer bacteria than an ultrasound probe that had been not properly disinfected, which is quite scary. The efficient cleaning of ultrasound probes is only one facet of the total process. There may be other aspects to consider which these articles addressed, and they include sterile gel, correct disinfection of the probe head, high-level disinfection between each patient, standardizing the guidelines, and training for staff. So what did I learn from my research, and how will it help me going forward and help my patients? I started with the question, what is the impact of automated high-level disinfection on microbial colonization in ultrasound and endocavity probes? The findings suggest that while some departments and countries do follow automated high-level disinfection for ultrasound probes, there is also a wide range of other disinfection being performed or not. Ultrasound technology is more widely used in a larger number of hospital departments than we realise. All staff need to be more aware of the risk posed to our patients from routine ultrasound procedures. Disinfection of the ultrasound probe after each patient is essential. Standardization, more user-friendly guidelines, and standard operating procedures for all staff is vital. More research is required into the use of sterile gel and probe covers. And when all of these factors are taken into consideration, it will help us reduce the transmission risk of healthcare-associated infections to our patients. This systematic review has shown that ultrasound and endocavity probes should be processed as a semi-critical device and be high-level disinfected using an automated system after every patient use. This is a validated and repeatable method of high-level disinfection, and this accompanied by education of all our staff, education, single-use gel, and suitable sheets and condoms will ensure our patient safety. Thank you.
Thank you, Ursula. So that's why, in line with guidance within Scotland, Ireland, and England, we can see that automated systems are considered best practice. Public Health Scotland published that there's a high-level published evidence to support the use of ultraviolet light systems for the decontamination of semi-critical ultrasound probes, and there's low-level published evidence to support the use of a manual detergent-based system, which could include different steps. So I'm from a company called Germitech, and we specialise in UVC high-level disinfection, and we actually won the award, the Prix Galien Award, for the best medical device. We specialise in two main product lines, which is the Chronos, which is for transvaginal and transrectal probes, and the Antigermix, which is for transesophageal probes and ENT nasoendoscopes. The Antigermix is the only UVC high-level disinfection system that's Class 2B in its classification. If any other product is classified as Class 2A, it can't be used as the end point of reprocessing. So for those of you that aren't aware, UVC disinfection uses UVC light. We all might have heard of UVA and UVB. That's what we apply our sun cream for. But UVC is actually absorbed by the atmosphere, so that's why we recreate it. And the reason for that is UVC uses a photolytic effect, whereby the radiation passes through the cell walls and damages the thymine bases within DNA. This stops it replicating and therefore destroys it, making it a very effective form of high-level disinfection, which viruses cannot become resistant to. So we harness this technology within our products with a special design that allows a proper illumination and efficient exposure to the medical device, which causes no shadowing. It's really important to us to ensure that our products are validated throughout the world, and we do that by performing carrier testing in laboratories and clinical in-use testing. At this point, I'd like to introduce Dr. Shannon Ali from UCLH, who will be able to talk to you about a study that we've performed in a laboratory.
Hello, good morning everybody, and thank you for welcoming me to this conference. My name is Shannon Ali, and I lead what's called the Environmental Research Laboratory at UCL Hospitals. And for the last 15 years, we've been working on various aspects of infection control microbiology, from designing, developing new antimicrobials, antiseptics, therapeutics, and also getting involved in infection control and outbreak situations with a view to manage infection control risks. One of the things that we also do, we've been doing for the last 15 years, is working with industry and trying to validate and optimize medicals for the products for the medical market. So we've heard a lot from Ursula about the field of disinfecting and decontaminating probes. What we do know and what we can see from her research is there's still a lot of work that we still need to do. Where we come in is we're interested in simulating these conditions with a view to find out what we can improve or do better. So this is a small part of a larger piece of work that we're doing, but this will give you a view of some of the things that we've done. So we know that the transvaginal ultrasound probes are used very widely in gynecology clinic sessions, and because they are used and become in contact with mucous membranes, there's a risk of either biological fluids or products or mucus to reside on these surfaces, and that then has an impact on how well these surfaces can be decontaminated. And we know that these biological fluids and soils can harbour bacteria, viruses and other microorganisms, and also protect them. There is also a risk that if they're not removed effectively, they could disseminate onto other surfaces, which will then recontaminate other parts of surfaces and clinics. So Ursula's mentioned some of the ways to decontaminate. There are two main categories, manual and automated. And just to give a little overview of the manual processing or reprocessing, it can be done either by immersion in a biocide, or it could be physical using either single or multiple wipes. With the automated reprocessing, the options are either UV irradiation or chemical using hydroperoxide vapor. We always have to be mindful about the processes and whether there are pitfalls as well as advantages to each method. With manual, we know that you can assure there's good physical contact, so you can remove the soils. But then the downside to this is, over time, we know through audits and other literature that there's fatigue in the training, and there's variability in how the decontamination occurs. When it comes to automated, one of the benefits of that is there's no discrimination. All of the surfaces are exposed to whether it's whichever route you use. But then we always have to be mindful that it has to be preceded with manual decontamination. So this is a short piece of work that we'll be discussing, comparing two types of automated versus manual reprocessing. And what we wanted to do to simulate the potential contamination on these surfaces was to use a range of bacteria grow these to a high titer, incorporate them with a soil, because we are mindful that soils will affect how well these are removed from the surface, and then we then subject them to the 3 types of reprocessing, so there's manual versus 2 types of automated. So in this slide you'll see a top view of a probe. So this is one that was decommissioned, so it won't be used again in a clinic, but we marked spots on this, and then we seeded the surface with the organisms that I described in the previous slide, with the soils, and then we cleaned them with the 3 methods. And then we sampled them using an in-house validated technique to be able to recover the microorganisms remaining on the surface. And we compared it to a control array that wasn't exposed to any kind of cleaning. So this is what we found. So with these 4 organisms, we found, regardless of the heavy or moderate soiling that was present, we found that all 3 methods were able to reduce the numbers from 6 log bacteria, so there's about 1 million CFU, down to about 4 CFU. So what do we know about cleaning in the absence of any kind of disinfectant or any automated reprocessing? We know that the manual process can move the bacteria around, and we simulated this as well in the laboratory to see how far bacteria would travel. So we found that if you were to seed a surface or multiple surfaces on a probe, and then you were to wipe it with a manual method in the absence of a disinfectant, you'd find that a lot of those would be removed, but a number of these would be accumulated towards the distal part of the probe. And in general cleaning, it occurs in one direction, you never go back on yourself. So we know that there will be spots where whichever type of reprocessing you'll be using, you would have to make sure there's focus or attention to these high risk or hotspots. So what we concluded from these is manual wiping can accumulate bacteria at distal parts of the probes, though all of the processing techniques we used were effective, and we found that automated technologies are also effective as high-level disinfection of transvaginal ultrasound probes. So we're going to look to take it further, because I discussed how we worked with bacteria, but one of the things that we know is soils can do have multiple effects. So not only do they allow the bacteria to reside on a surface, but it also protects the surface from being cleaned effectively, but it can also quench the activity of some chemical disinfectants. So we're going to simulate these situations by using more representative soils, such as mucus. The other thing that we'll be interested in is, we talked about using bacteria as a model to simulate the cleaning and reprocessing, but we're interested in HPV transmission, since it's implicated in cervical cancers. And what we'll be doing is using HPV or a surrogate to determine whether there's any risk when using these processes. I'd just like to thank my team, who did a lot of work behind the design, optimizing and methods and generating the data, some of them who are in the audience over here. So I'd like to thank you for listening to the work we've done.
Thank you, Shannon. So hopefully that gives you everyone a little bit of reassurance that not only are we invested in providing our products, but also evaluating the efficacy, both in a laboratory, but also in clinical use. So this is a recent paper by Professor Maxime Pichon. And what we found in this study was when we compared our automated UVC high-level disinfection to a chemical impregnated wipe, we found that there was elements of human DNA and HPV present on the probes, whereas after an automated method, that was not present. So there's many benefits of using UVC high-level disinfection, apart from just being an automated solution. And one of the key things is time. Our product's from as fast as 60 seconds, so it supports the workflow of the sonographers, and it doesn't delay them. We also found that an independent study conducted by Imperial College London found that our product saved than 55 minutes and 45 seconds of extra time every scanning session. So every morning and every afternoon, they published that would allow them to scan extra patients. Compliance is a really big thing, especially for sonographers, and it's really important to consider a disinfection method that they're happy with. And what we also found was 98% of users preferred using our product compared to a manual stage system. Probe compatibility is obviously very important, and we work with all the manufacturers to ensure that our products are compatible. Not only do we consider the materials of the probes, but we also consider shadowing. So we would only consider a probe compatible if we found that there's no shadowing on the probe. Obviously, efficacy we've spoken about in terms of effectiveness, but obviously areas of the device. We're the only automated solution that high-level disinfects a handle of a transesophageal probe as well as the tip, and other automated solutions for transvaginal and transrectal probes actually clamp in at the strain relief. We actually high-level disinfect the whole probe, the strain relief, and a high proportion of the cable. We're a very sustainable and cost-effective solution. UVC high-level disinfection doesn't require any chemicals or an ongoing supply chain, and there's no waste. Ensuring that we're fully automated and traceable and auditable is really important for us. We have an independent control system that doesn't require the operator to verify if the cycle was successful, and we also have an inbuilt software that can be connected to the IT, or we can use labels. We can support the practice. So as a summary, we have all the efficacy required to high-level disinfect ultrasound probes. We're an automated technique. It's the fastest technique on the market. We use no chemicals, it's completely traceable, and it's a sustainable solution.